All right, welcome. Again, thank you for everybody for coming out. We will be doing a Q&A with this wonderful panel, and then we'll open it up to audience questions. And when you have questions, if you'd like to at any point use the Q&A function, which should be at the bottom of your screen. If you have trouble with that, then go ahead and use the chat and we'll do it that way. But if you use the Q&A, I think you can do it anonymously. So that also might be nice because these can be sort of sensitive topics. So let's go ahead and get started. I would love for our panelists to introduce themselves. If I can call on you and you give me your name, your position, and where you were working, and then just a brief little synopsis of kind of your experience or your interest areas, and then we'll get started with the questions. So if you want to start, I'm just going to go on my screen here. So Amy Carlson, if you can start.
Hi, I'm Amy Carlson, and I was asked to be on the panel because just in the last year, I have spearheaded and am developing with other end-of-life doulas a collective of end-of-life doulas who work with people who are coming into the final part of their lives and helping them to make the transition off this earth as good as possible. And the impetus for me behind this work has been, came from helping as a hospice volunteer for Midland Hospice. And I think I'm in my 5th year with them. And from there, I've just gotten a really more and more interest in learning and helping with end of life.
Thank you. All right, Dr. Wenzel.
Sure. So my name is Dave Wenzel. I'm the Chief Medical Officer at Midland Care. I've been a hospice physician, hospice palliative care physician for almost 20 years. I did a family medicine residency and then a hospice and palliative medicine fellowship, and so I'm board certified in both. And all of my career I've spent working in hospice and caring for dying patients. What prompted me to work in hospice was I became a hospice volunteer actually before I went to medical school. So I was a hospice volunteer even before I went to college. And had a grandmother and then a grandfather who both died under the care of hospice, and was so amazed at how they took care of them and my family that I always knew I wanted to practice that kind of medicine. And I think hospice and palliative care is practiced the way medicine should be practiced, in an interdisciplinary team way. And it also harkens back to the way medicine used to be practiced when we did home visits, and that, because one of my favorite things is doing home visits and seeing patients in their home environment and that sort of stuff. It's very rewarding. So I guess that's why I'm on this panel, and always enjoy talking about end of life issues and dying. It might come as a big surprise to everybody, but we're all going to die, and so not talking about it doesn't make it go away. And so we need to talk about it. And it's so unusual now that we're in the middle of this pandemic. So I think it has brought this conversation to the forefront in a lot of places.
Absolutely, I agree. Thank you very much. Monica Rose.
Okay. Sure. I'm Monica Rose, and I am with Visiting Nurses Hospice. I'm the hospice team manager, and I have been with VNA about 5 years. I've been in hospice 16 plus years. It's the love of my life, I guess. I have done other types of nursing, but I always fell back to hospice. And I actually got involved with hospice when I was a long-term care director of nursing. We were working very closely with a couple of hospices, and it just felt like it was the right thing to do. And I've been doing it ever since.
Wonderful. Thank you. Nicole Apprill?
Hi, everybody. Yes, I'm Nicole. I am a nurse practitioner with the Palliative Support Services program at LMH Health. I've been here a couple of years, and I actually worked with Dr. Wenzel over at Midland for a while. So my background, I was a critical care nurse, and one of the things that we saw was this repeated cycle of patients coming in and having critical illness and progressive decline secondary to their critical illness or their chronic illness. And one of the things that was so distressing as a bedside nurse was, are we honoring the patient's goals and aligning their care with those goals? And that was really a big prompt for me to go back and complete my master's degree and become a palliative care nurse practitioner. My journey's been a little bit interesting. You know, I worked with Midland for a while, and then I actually worked at KU in their trauma program for a while. So kind of swung the other way for a while. But certainly there's a place for hospice and palliative medicine in trauma, and how do we manage patients in those situations? And so, but I ended up coming to LMH, and it's been a really great transition to be here.
Thank you. And Kathleen, do you want to introduce yourself?
Sure. My name is Kathleen Morgan. I'm the Director of Development and Community Partnerships at Lawrence Public Library. And I've been fortunate to be part of the team here at the library that has been putting these programs together. The series is called Before You Check Out. And we've been doing classes in regard to end-of-life planning for the last couple of years, very closely with the hospital, where we talk about advanced directives and estate planning. We've had a number of book talks. Being Mortal was a real popular one that we have done, but it's been a whole variety, kind of a universal look at end-of-life issues, including recording your life story and writing your own obituary, that sort of thing. So it's been really rewarding for me personally, and I know we've gotten a lot of positive feedback from the community. So I'm excited to see that this series is continuing, and these issues, like Dr. Wenzel said, continue to happen. I think one of our speakers said when he was giving a speech to a really large group at the library auditorium, it's like, I see 100% mortality in this room. And it's really, really important, I think, to talk about these issues in advance and help your family kind of come to terms with things. So thank you to Kate and the other panelists for joining us today. We really appreciate it.
Absolutely. So we've got some questions here, and I'd like to go through them. They're going to be, some of them are going to be open for everyone to answer. Others are going to be kind of specifically geared to different professions or areas. So I will go ahead and ask the questions, and then go ahead and you all can jump in with your feedback when applicable. So the first question we've got is, when do you know it's time to switch to hospice? And then I've got a couple of follow-up questions about hospice after this. So,
Okay. I think that we always try to let the families know that, you know, when you're starting to see that decline in functional status, when those aggressive treatments are no longer working, when your family member is just to the point that they're just tired, they don't want to do these treatments anymore. I think that's the obvious time to consider hospice. And I think that palliative care, when it's applied more in the beginning, they can kind of help direct those families when it's time for hospice. They kind of get them geared towards that. And I feel like that's where palliative care and hospice really work the best together. It's never too soon to start those medications and to be treating symptoms as opposed to the aggressive treatments. And if you want to continue with aggressive treatments, that's the time for palliative to get in there and get started and help control those symptoms. And then as things kind of progress, that's when it's time to let hospice slide in and just keep the patient comfortable.
So this is Dr. Wenzel. So this question comes up all the time. And so I think it might be better to maybe start at the beginning rather than the end. So let's start at the beginning. So how did we get to a place where this would even be a question, right? Because before hospitals were built, everybody died at home. There was no place for them to go. And families took care of them there and sat with them and stayed with them. And so it's really only at the advent of modern medicine that we've had this dilemma of when is it appropriate to tell someone that they're dying? Because when we say it's time for that's what we're saying to them, right? That's what they believe or that's what they hear. And then the other issue is we really also have to be honest and truthful about the fact that this is really all wrapped around the Medicare hospice benefit. That's what the struggle is all about, right? So the Medicare hospice benefit, when it came to be in the 1980s, early 90s, it was a group of programs of people got together, volunteers in small communities like Lawrence, Topeka, and those places, and they just saw that people were dying in the hospital in really horrible ways, painful, suffering, those kind of things. And they just felt like there had to be a better way. So they started this idea of hospice where people would have the option of being able to die at home if they wanted to. So Medicare said, yep, this after the demonstration project ran for a few years, they said, yep, this looks like a great thing. We're going to make it an automatic part of the Medicare benefit. So anyone who's on Medicare can have access to this kind of care. But the question to the group was, well, how long should people get that if they really need it? And someone in the group said, well, how about 6 months? How does that sound? And that's how that came to be. I know that because I have worked with a couple of the programs that were in the original demonstration project. So Medicare asks medical people like Nicole and myself to be able to tell if a person's disease runs its normal course, they have about 6 months or less to live, to say that they're appropriate for hospice services or the hospice Medicare benefit. That's the regulation, right? And so that's the struggle that we always have, because the question I always ask everybody is, well, how good do any of you believe we are at being able to predict that? Well, we're terrible at it. We're really bad at it. It's so bad that every study shows that medical professionals or providers who predict those things have a tendency to overestimate by a factor of 5. And so that's why most people in the United States only get about 2 weeks worth of hospice care. 14 days, 16 days, year to year. It's the average amount of time across the whole country that people get that care. It changes a little bit every year. So when people say to me or ask the question, when is it appropriate for someone to be on hospice? It's really hard to tell, because if we believe they have about 6 months or less to live, they're definitely appropriate under the Medicare regulation. But the problem is when we wait to say that someone has about 6 months or less to live, they usually only live about 2 weeks. So I don't have a great answer for that, other than to say that the most difficult thing for families and patients is when they are dying and no one talks about it. No one, the doctors don't talk about it, the family don't talk about it, no one wants to talk about it, because we live in a society that believes in magical thinking. And magical thinking is, if I talk about the fact that I might die someday, it's going to happen sooner, which isn't real. And so we live in that sort of mindset all the time that, well, there must be something else we can do to keep our bodies going. And doctors function that way too. I mean, we were kind of trained that way. In medical school and residency, you look for what the problems are and you come up with a treatment plan. And if that treatment doesn't work, there's this thing you could try or this thing you could try. There's always more things that can be tried medically. The problem is we've learned that many of those medical things don't extend life. They shorten life. They make people's lives shorter. And often people suffer when they're going through those things. And so the discipline of palliative medicine was born out of the fact that there was still a lot of people who were only getting end-of-life care or hospice services for just a few days or a few weeks, who were suffering tremendously. And so, so when to have that discussion and talk with someone about when they're appropriate for hospice is not very easy, because doctors don't know. I say this all the time when I'm talking to families. I can't even tell you if I'm going to be here in 6 months. I don't know. I hope I am. I'm healthy, but I can't see into the future. And so it's really hard. And so that's why I say everyone should periodically be having these conversations about how they want their care to be directed, especially if they get into a circumstance where they lose capacity, they lose understanding and ability to make decisions. Because if they lose capacity and no one's talked about it, well, then we get these horrible cases that often end up in the courts and all that stuff that's just not necessary. If people would clearly state what their wishes are, their values and their goals, and as Nicole said, then we try to make the care that we're providing them align with us. We need the care that we're providing to align with their goals and their values. And always, no matter what, we need to try to address their suffering. So that's a long answer to a question, but there isn't really a good answer.
Right.
I'd like to add to that. And what we're talking about here is quality and quantity. We try to quantifying things. And what Dr. Wenzel was saying, we can't quantify it because we don't know, but we can understand quality. We can understand how we envision things for ourselves. In Midland, I also hang out with patients who are in PACE, which is basically is nursing home care for people who are poor. So I get to work with them way before they'll ever be on hospice. And I can tell you that having that time and getting them to understand what their values are and where they want to be is so much better by the time they go on to hospice. Because indeed, like one person I was with for 4.5 years, and she was on hospice for a day and a half because her death just came and she went. And so this idea of, hospice being this qualifying moment really isn't accurate.
Well, how long can hospice care last? Like, say you do decide to go into hospice care when you have maybe 6 months, and that 6 months passes. How does that happen? How does that work?
As long as the patient continues to meet the Medicare guidelines for hospice under that diagnosis, there is no limit to how long they can be on hospice. For the first 6 months that the patient is on, we reevaluate every 90 days. And then after that, it's every 60. And as long as they're continuing to meet all of Medicare requirements, then they stay on. Occasionally we get to graduate somebody, and that's great for them. Typically they come back on, a month or two later, or 6 months later, but there's no limit to how long you can be on, and there's no limit to how many times you can go off and come back on.
Okay, that's good to know. And just to kind of cover some basics, so hospice is it always in your own home or in one's own home?
It's what you consider. It's wherever you consider to be home. So it can be in the nursing facility. It can be in your own home. We've had patients in the shelter before. So we meet the patient wherever that patient is at, and try to meet their goals as best as we possibly can in their circumstances.
Thank you.
I'll just add to that. There are certain situations where patients are not able to remain in their home or in their whatever is considered home, so whether that's a nursing facility or in their home. Typically, those patients are having uncontrolled symptoms that we cannot get managed at home. And so there are situations where we admit to the patients to the hospital under inpatient hospice or to a facility like Hospice House to have those symptoms managed more aggressively. I call those situations, I call it ICU for symptom management. So like you would take a critically ill person to the ICU to treat their critical illness, this situation, their critical illness are their symptoms. And so we bring them in sometimes to allow them to be more comfortable with more aggressive regimens that we can't administer at home.
Sorry,
go ahead.
No, go for it.
Oh, I was just going to say there was a question about the coverage and about insurance coverage for patients who survive longer than six months. And so, like Monica said, if patients continue to qualify, then their insurance should continue to cover that. And the same thing goes for inpatient hospice. If their symptoms meet that, if we can meet the burden of proof that those symptoms aren't manageable at home and that patient needs to be cared for in a inpatient setting for aggressive symptom management, that will be covered by their hospice benefit as well.
Okay, thank you. To back up just a little bit, could someone explain what palliative care is, where it's available, and how that communication goes with one's existing doctors, like their family practitioner or other people?
Yeah, so palliative care, think of it as serious illness care. So most of the patients who are seen by palliative care are patients who have generally chronic progressive illnesses that are serious in nature, or an acute serious illness, maybe in the hospital. And so the idea is that, and again, the primary goal is to kind of elicit the patient's priorities for their life, make sure that they have a good understanding of their illness and what they can expect as their illness progresses, and then marry those goals with the disease-specific treatments that we can provide them. So I think it's easier to explain that with an example. So let's say that you have a patient who has a cancer diagnosis. And at first we start with chemotherapy and we start with radiation, and they're not having a lot of symptoms. So palliative care comes and says, hey, we know that you have this serious illness. We want you to know that our services are available. We want to be available to offer those services to you when you're ready or when you need them, if you need them. And so as they undergo treatment, maybe their cancer progresses or they start having increasing shortness of breath or pain or those kinds of things. So we can step in and start assisting with symptom management. As those treatment options change, or as the patient begins to say, I don't want to do those things anymore, I don't want to undergo these aggressive treatments, then let's talk about how we can adjust your management to ensure that we're honoring that. And so palliative care sort of steps up their services over the course of time as disease modifying management goes away or it becomes ineffective. And so one of the things that makes me a little bit crazy is when families or friends or people say, well, they fought this and they just couldn't overcome it. No, our treatment options couldn't help that person. Their body couldn't respond to those treatment options. And so I try to make sure that it's we have all these super cool technologies, but we can't always make a difference because bodies fail. And so how do we make sure that they are comfortable as they go through that process? A lot of what we do at the hospital is goal setting, goals of care conversations. How aggressively would you want us to treat you in this situation? Some symptom management, but primarily at the hospital, we do a lot of goal setting.
And so who, as far as how it's covered or how it's paid for, who qualifies for palliative care? And is it available even in rural areas, or is it kind of location specific?
That's a great question. So anybody who has a serious illness should be eligible for palliative care. And so ways to get a consult, you can always call the office. and say, hey, I'd like to be seen by the palliative care team. I have, these things going on. And so we can our nurses can kind of triage you through that. And so, you can always talk to your provider. So let's say that maybe you have heart failure and your symptoms are getting worse. You can always talk to your cardiologist or your primary care provider, say, hey, I heard about palliative care. I wonder if this would be something that would be helpful for me. And we can always get a visit arranged. I think, and Dr. Wenzel, I'm curious to know your thoughts about this, but with the changes that we've had with COVID-19 to our ability to provide telehealth, I think that it's greatly expanded our ability to serve patients who are not, or people who are not local to us. So we could see people that are, 2 hours away. Frankly, I could probably see somebody in my hometown out in Western Kansas. They would just need to have an appointment set up, and we'd have to make sure they had access to a telehealth platform so we could get that done.
Yeah, I think that's greatly expanded access to palliative medicine in terms of around the whole state, because there aren't, there's only really a handful of medical providers, contrary to what a lot of communities think. There's only a handful of medical providers who have the training and expertise to provide palliative medicine and even hospice care, even though oftentimes in the smaller communities, whoever's the local family medicine doc ends up being the hospice medical director, or like in Topeka, where there's 20 different hospices, a lot of the other hospices there, they just ask one of the internists, local internists, to be their medical director, which is fine, but they don't have the same, they did not do a fellowship, they're not board certified in hospice palliative medicine, that sort of stuff. They're good doctors. So telemedicine's really expanded that, and COVID-19 has really brought an emphasis on that. One of the things I want to correct a little bit, because I hear several people saying this, that patients go on hospice, or they're on hospice, or we put them on hospice. The patients are actually electing their Medicare hospice benefit. So they're actually electing the benefit. It's a benefit that's available to them if a medical provider certifies they believe their disease running its normal course, they have about 6 months or less to live. They can remain on hospice services enrolled in their hospice benefit as long as a medical provider will continue to certify that. Initially, 90 days, then every 60 days, that certification has to be done. Medicare put in new regulations a few years ago that after the first 6 months, there has to be face-to-face visits minimum every time they do a recertification. So the physician or some representative of the physician has to see that patient to do a medical exam to make sure they still meet the criteria. But it's really the individuals electing their Medicare hospice benefit. Or if they're under insurance, Blue Cross Blue Shield, whatever, it's electing that benefit of their insurance. We don't, sort of put them on hospice. That's the question. It's like always we're putting patients somewhere else or doing something else with them. They're just electing part of their insurance benefit, and it's meant to be by the regulations in the last 6 months or so of their life. But remember, that 6-month number is totally arbitrary. It was just made up. It was never studied or looked at in terms of its benefit or usefulness. It was just made up in the group who originally did the demonstration project. So being able to determine that, and then palliative medicine really has helped a lot, but the struggle there is palliative medicine is only paid for through clinical interaction, through billable visits. So there isn't a per diem where, some of the DME is covered or meds are covered or time with social worker chaplains, PT, OT, all the different disciplines from hospice. Palliative medicine has an interdisciplinary team, but none of that stuff is covered. And so only organizations like Lawrence Memorial Hospital or Midland that have a commitment to providing service in the community will do it, because it absolutely loses money everywhere it's put in place. You cannot bill enough visits to cover all the interdisciplinary team and all the amount of time that goes into caring for these families. And so it's only through community support that's continued.
That's really interesting. Thank you. We're going to have some more questions about palliative care, and I know we've got some audience questions that will be coming up shortly, but I do want to hear from the death doulas and learn a little bit more about how it's different from a hospice nurse, what kind of services you provide, how long the services are provided, that sort of information.
Okay. Well, the main difference between, like I said, I kind of came around to end of life doula as a vocation from being a hospice volunteer, because what I realized early into it was people going into and at the very end of their lives need time. And Dr. Wenzel was just saying, real care come at that point in somebody's life. The care is from person to person acknowledgement and encouragement and love. And palliative care and hospice work very hard and very well at managing comfort. But there's another part of the person who's at the end of their life, and that's their human, spiritual, whatever it is, who they are. And when you watch people die, what I recognize is they're transitioning out of this world with the same spark that they came into it with. And it seems like what happens is everyone who's seen a baby knows this. They're so perfect. They're so pure. And then life happens and we get the hamster cage brain thing going on and we're busy. But at the end, when time becomes compressed, we need to find that person again, because, and one thing I love about being with people at the end of their life is they know that. And it helps me to recognize not to lose that. Don't lose sight of that. I thought of something this morning and I said, what if we just had the end of the day doula? Like, how did I get to the end of the day today? Like, if I did that every day, I won't need an end of life doula because I'll be ready. And so that's kind of the difference. And mostly what we do is we just meet people where they are. I think that Nicole was talking about how people will say, oh, well, it was a failure. They went through all that treatment, it was a failure. Death is not a failure, it's just a fact. And where I think those comments come from is the expectation of the person who says it. They don't want their loved one to die. They're putting all their money on this treatment. They want it to work. But that can't go on forever. And a doula has no expectations of their patient. We don't know them for a very long period of their life, really. And so they're freed up to find the essence of who they are without the expectations that other people and other systems in their lives have required of them and require of all of us all the time. So I think that is the keen distinction on end-of-life doula care and how it is differentiated from these other modalities that we're hearing about. They're all important, but so for end-of-life doula care, I think I really would love it if people would just start, even if they don't work with somebody specifically, just started learning about that as soon as they get that cancer diagnosis, even if they get better, because they will do better through their treatment if they have that mindset. And the same with people who are frail. I mean, it's so funny. Frailty is part of living. You get old enough, you're going to become frail. And then we say, oh, they're going downhill. It's just a fact. And so also elderly people in particular, I mean, just listen to them because that's what they need to have happen. So anyway, I'm rambling on, but those are the, that's the distinction, really.
And I would agree with Amy. We I became a doula, as well as our social workers, mostly just so that we could help those have an even better understanding of how to walk those patients through that process. And we also are doing like little bits of training with our nurses, because at the end of life, especially as Dr. Wenzel said, we get them so late that the nurses are tasked with managing those medications, and and they're just always in task mode, going and going and going, trying to get the patient comfortable and those kind of things. And that's where our social workers can come in, and they can kind of help the family deal with the decisions that the patient has made, so that we can help them reach an understanding, so that they can grieve appropriately, as well as walking that patient through. I always like to refer to us as the tour guide on the patient's journey. It's our job to make sure that they get the best experience out of this journey that they chose, and we try to get to know the patient if we are allowed that time, get to know that patient, and make sure that we do things how they would have wanted them done, and then help the family kind of understand, this was their choice. This is why it was important to them. And you're helping them achieve their final goal. So that's kind of how we have used our doula training, more just to help our team. I feel like we do a great job communicating with the families and loving on our families and patients, but it just kind of helps us kind of reorient ourselves and think of that whole person, as opposed to a job that has to be done.
Okay. So what I'm hearing is that it's not a one or the other. It's a more of a holistic sort of whole person.
It's a non-medical. Yeah.
Gotcha. Okay. And so you both mentioned kind of helping the families and helping the loved ones and the ones who are end up being left behind. So how long can you provide those services to those family members and those loved ones?
Well, Medicare, the Medicare guidelines are 13 months. Sometimes the families after 6 months are like, hey, I don't feel like I need anything, but we always make even with those families, we make that phone call at the year mark. And I think that Medicare did that the 13 months, because at the 1 year mark, things kind of come flooding back, and there's things that maybe you thought that you had dealt with that maybe you hadn't. And that gives our team an opportunity to say, hey, we have other resources available to you if you feel like you need some more time, or even have them come in and do a one-on-one counseling, whatever is appropriate for that family member at the time. But we do follow them for 13 months unless the family is just adamant that, we don't need anything. And then we just do that follow-up at 1 year.
Just to check. Yeah. Okay. And so 13 months after, and
Yes.
I guess how much time is it like hospice, where it's just as long as they qualify for the person who is dying and using those services? Is it
For the bereavement?
No, for the actual person whose life is ending. How long are your services allowed?
There's no cutoff time. As long as they're still qualifying, then we can continue to go out. And obviously, if they're making those changes, and then they're going to continue to qualify. So it's not like we're going to just drop the patient and say, sorry. Even if we do have a patient that we feel like we're graduating, we feel like needs to graduate off our services for a little while, we still stay in contact with that family, try to make follow-up phone calls and make sure that they're still doing okay. Sometimes we refer them to home health. We try to make sure that there's still some kind of service available to them, even if it's just us calling for a little bit of reinforcement, saying, you're doing a great job. How are things? Are things still going okay? So, that's a hard question to answer, because even when they graduate, we still are trying to keep track of them and stay involved.
Because you care about them as a person. That's the whole
Yeah.
point. Yes, absolutely. And so do all of you. Okay. And so for these sorts of services, if you are just kind of like we're just diagnosed, or someone in your family was just diagnosed, and you're lost, and you want to know, where do you start the process of contacting these different services? Do you just suggest kind of talking to your physician and talking to the doctors that you already have access to, and then having them get you connected?
Yeah, I think that's the best way. Sorry, go ahead.
Yeah, this just happened this week, and usually, sometimes there's a family member who will like take the lead, and they're going to get everything set up and get everything going, and so we'll get calls like that, and generally what I'll do is corral that person and the person they're calling on their behalf for, and try to find out what the goals, where they're at. Usually it's panic if they've just gotten a diagnosis or something like that. And so I'll just explain what's available to them in their community. And then kind of just be, like I said, sort of that person that doesn't really plug into anything in particular, but these are the parts. This is how this will help you. I'll talk to them about how hospice works. Like, you don't get put on hospice, you just choose that level of care. And usually it's just, and I imagine Monica can say this too, it's sort of talking them down and getting them calm enough to be in their mind in a way where they understand that they have some power that they can exercise in terms of how things are going to play out.
Yeah, I would definitely agree with that. And, typically it's best to start with your physician, but sometimes they just, like, maybe they're new to the community and they don't have a good relationship with that physician, or don't feel comfortable, or I get a lot of calls during the day about, I don't understand hospice. I know that we're probably going to need it, but I don't know when. And so I just kind of talk through with them what hospice is about, and then what other resources are available to them until they reach that point. And then I encourage them to I kind of give them like a few pointers as far as questions or how to start a conversation with the physician, just so that, because I feel like it's important that their physician obviously is on the same page as them. So I try just to give them some pointers and help them figure out a way to best communicate with their physician, and then give them other resources, of course, because usually, like Amy said, it's panic mode. It could be a brand new diagnosis, and there may be treatments out there that are going to work for them. I don't ever want to just say, oh, well, you have a cancer diagnosis, you need to be on hospice. That's not true. We want whatever their goals are is what we want for them. So we just kind of help them walk through that process and point them in the right directions.
Okay, thank you. And as a practical question for all of these options, palliative, hospice, and death doulas, what are the kind of forms? What are the procedural sort of things, like forms you have to fill out, people to contact as far as treatment coverage goes, that sort of thing?
For hospice or
any of these kind of, what forms can you expect for each of these options?
Well, from our end, on the hospice end, it's more the admission paperwork. It's agreeing, admission agreement and election of benefit and those sort of things. Because those are what Medicare wants to see. That's the information that we submit to them. And then they don't have to do anything after that. Once they have signed the admission paperwork, we take over the billing. They should never receive a bill for hospice services. If they choose to go to a doctor maybe that we don't know about, they might get a bill because but we usually end up taking care of that bill for them. But but once they sign that admission paperwork, then that's all on us. We help guide all of that. So
one thing I'd like to add, and I think Dr. Wenzel pointed this out a little earlier, is if you're going on to hospice, do a little research on the hospice. Because there are statistically, there's just a whole lot of people that are on the verge of going into end of life right now because of the demographics. And some of these hospices are like showing up like Jack in the Box burger joints. I mean, I got a volunteer email. Would you like to volunteer for our hospice such and such? Because I'm on some list somewhere. And I was like, oh, I've never heard of this hospice. This is a new one in my town. So I start Googling it and stuff. And I'm like, it's in a strip mall and the head office is in Santa Barbara, California. And, Douglas County VNA is a community-based health and, our public health, entity. Midland Care has been a community-based hospice and bereavement community or in our community for years. And so, I heard somebody said, well, I just picked this hospice because it's closest to my house. I'm like, no, find the ones that are entrenched in your community, because those are the people that have their tentacles out. They're doing fundraising. They're doing everything they can to be able to have enough money to spend time with you. And so if anybody's listening to this and you feel like, oh, I may have to be on hospice, do the homework, because it'll make a big difference.
And talk to your
Well, let's talk about one of the biggest misperceptions, though, about hospice service and Medicare in general. So I think we should be saying this in every meeting, every group, because I hear this every day in my job. Medicare does not pay room and board at a nursing home. It never will. It never has. When people go into a nursing home for a skilled nursing stay, Medicare will cover sometimes up to 100 days at most of the room and board. So I hear this every day. Why didn't somebody tell me this? Well, if you read through the Medicare information that's given to you when you enroll in Medicare, it's there. It's in fine print, but it's there. Medicare does not cover room and board at a facility, assisted living or home plus or residential, or Medicare doesn't cover that. Hospice doesn't cover that. Hospice can't afford that either. And so the question that often comes up about the Medicare hospice benefit is, what things will it cover in terms of paying for? As Monica said, it pays for anything related to what's listed as the terminal diagnosis on the election form. So when we submit to Medicare, the Medicare election form, we have to submit a terminal diagnosis. So if it's cancer, what type of cancer it is, then the stuff related to that cancer care, the hospice has to pay for. So that's one of the reasons why we often say to patients, well, when you enroll in hospice, you can no longer get chemotherapy, because if the hospice had to pay for the chemotherapy, they would be broke in 2 days probably. I mean, most chemotherapies are thousands of dollars. And again, I believe in transparency. Let's be transparent about all this. So when someone elects their Medicare hospice benefit, Medicare pays the local hospice, that hopefully the local hospice that they enroll in, they only pay them about $90 a day. We bill about $120 or something, but Medicare will only pay us 80% of what we bill. And so they only pay us about $90 a day. And that has to cover all the DME, all the disciplines and visits, all the medications, anything related to the terminal condition. Now, when I see a hospice that says they have a return on investment to their shareholders of 20% or something like that, I'm like, how is that possible? The only way I think that's possible is if they're denying certain things or not paying for all the things they should be paying for. Because hospices who really do what they're supposed to do, there's no return. There's no, you know, we're providing care. We're doing $500,000 of charity care or more a year. We don't have any money left over. We're out beating the bushes trying to get the pennies we can to care for the people who don't have insurance. So when you talk about looking at hospices, you need to really be aware of what the Medicare hospice benefit covers, what it pays for, and what the hospice you're choosing will talk about in terms of what they will cover. Because most of them, very few of them have, like Nicole said, that general inpatient level of care. Many of them don't have all the services that VNA provides or Midland provides in terms of the interdisciplinary care. So you should do your homework, but you really need to get educated about what your benefit is. That's the thing that surprises me. Is it would be like me, you know, my insurance I currently have, it would be like me not knowing anything about what's covered. If I'm going to go see somebody and I don't look in there and see, well, is that covered or not? And I get a bill and go, well, why am I getting billed for this? Well, if I read the explanatory note of what I have, what coverages cover and what they pay for, then I would understand it better. And I might choose more wisely what I decide to have done or ask for treatment, that sort of stuff. So it's really about education and understanding the Medicare benefit itself in terms of what it actually covers. Never covers room and board at nursing homes. And I have that question almost daily in my practice.
What resources would you suggest for someone who maybe is having difficulty understanding their benefit coverage, or
they should go sit down and talk to their senior center, right? The senior centers in every community have advocates there to help them look through all of that. And the other thing that we see all the time is these sort of companies fly by night that get people to enroll over the phone in their Medicare Advantage program or whatever, and they're billing them hundreds of dollars a month for something that they're not getting anything for. So everyone should be more educated. And if you have frail elderly people in your family, you should make sure they understand and you understand what their coverages are and what gets paid for and what doesn't. Because that's where the problem lies, is people don't research that information well enough and don't understand it well enough.
Okay, thank you. We will have some questions from the audience. I've got a couple of other things to kind of cover real quick. So for the future,
hey, sorry to interrupt you, Kate.
Yeah.
Kate, I'm sorry to interrupt you, but I am going to have to jump off of this.
Okay.
I'm sorry, but I have some things I got to go do. So
totally understand.
Nice to talk to everyone, and hopefully we can do this again.
Absolutely. Thank you, Dr.
Bye.
Wenzel. Bye. All righty. So this may go into some of the audience questions, but what are some things that you wish that more people knew about your profession?
So I think that, and this is prevalent amongst community members, but also amongst other care providers. Palliative care still, even though it's been around for some time, is very much equated to hospice care. And that if the palliative care team shows up, then I'm dying. And the fact of the matter is that that's not always the case. And so that is something that I educate community members, patients in the hospital, and my colleagues on a daily basis. We talk about how my role is supportive care for serious illness, and that's the language that I like to use, because that's exactly what we're doing. We're here to support you. How do we support you? We help you identify what's important to you. We help make sure that your symptoms are controlled. Palliative care is its own medical specialty. So it's just like going to the cardiologist. It's just like going to the urologist or oncology, whatever it is. People don't understand that. And so we are really, that's probably the biggest struggle for me. I think the other thing that I wish that everyone knew is that if you, even though it's not fun to talk about your wishes, the things that are important to you at the end of your life, or if something were to happen and you couldn't wake up and say to the healthcare team who's caring for you, I don't want you to do these things to me. If you can talk about that with your family before that happens, and identify a decision maker who knows your wishes beforehand, that is so much easier than us trying to have to guess and help families kind of say, well, no, dad really values these things. It makes it so much easier if we've talked about it beforehand. Even if the end of somebody's life is 15, 20 years away, having those conversations early makes a massive difference in our ability to help families digest and process these super difficult times. I can go on about that for a really long time, so
Yeah,
I'll let other people talk.
I think that, spending the time up front, and so that people do understand what your values are. Like some people, they're gonna fight a fight all the way to the end because that's who they are, not because they're valiant or anything else. That's just core who they are. Other people are like, I've had a good run and I'm fine. But when those, I'm not even going to say conversations, yes, but I mean actions as well. When you live your life that way, going towards the end of your life, and your family is witnesses to that, when you die, their grief is going to be so much easier than if it's all just up in the air and a big question, because that's when all the what ifs and why this and why that occur. If they know, and then people have like a grounding point for when those questions invariably start. They're like, well, I know why, because they said this, or they wanted that, or they lived this way. So it all goes together. And really, we know that we know to live every day as well as we can. And that's the reason why, because they will be over one day. So that's one thing that I think is misunderstood, that, we're just like the gloom and doom, grim reaper. It's the big failure at the end of the trip. And that's not it at all. It's actually quite celebratory if you make goals and live your life that way. You'll have a real life to celebrate.
Thank you.
Yeah, I agree with both Nicole and Amy. I mean, I think that the biggest thing that I wish that people knew was that when you elect your hospice benefit, that doesn't mean that you're dying tomorrow. What that means is that you've made the decision that you're going to just do comfort care, that you're going to live your best life the best you can for as long as you can. And you don't want to do all of those invasive treatments anymore. So, and sometimes, I mean, the reason that we have to graduate people is that they do better when they have a team of people that are going in there and looking at them every day. I mean, it's not, the team itself doesn't go every day, but one of the team members is pretty much, looking at, putting eyes on that patient, or at least talking to that patient almost every day. So they have a lot of support. And sometimes it's just knowing that those people are there, and you just start to bloom again, and then for those that, naturally the majority of them are gonna die on hospice, but they have a much, I feel like they have a much better death. They've had time to make relationships with the team. The team has had time to get to know them and to know what their goals are, and to deal and to help the family work through all of that. So I think it goes better for the family and the patient. And I think what I would like for people to know more than anything about death itself is that death can be beautiful. I always say that the patients give back more to us than we could ever give to them. They let us in at a very intimate time of their life, and it's just our job to make sure that it goes the way they want it to go. And I have sat at the bedside through many, many beautiful deaths, it's to me, it's just an amazing. And I think, Amy, referring to being just like birth, and recentering it on that patient itself. And I think she's right. It's just it's not about giving up hope. It's about changing what your hope is. And it's about hoping for the best life that you can live for the time that you have left. So I wish that people would could know more about that, that it doesn't have to be a bad experience. It can be a very beautiful experience.
Well, I really appreciate that. And one of the kind of purposes of this whole panel is to not only talk about kind of the experiences that we will all end up going through, but also kind of reflect on experiences that may not have gone the way you had planned when you lose a loved one. And Kathleen, I was wondering if you could just share that story that Kathy shared.
Sure. This comes from actually a fellow staff person here at the library. And she wrote that her mother-in-law died at age 94 of stage 4 lung cancer. And when we heard it was stage 4, we asked about hospice care and was told she was already getting palliative care. During the next few months, she was clearly failing. I'd bring up hospice and got similar reassurances, which kind of felt like sidestepping. Finally, I looked into it myself and decided to engage a local hospice. They were wonderful, and it was completely paid for by Medicare on top of it. She was on hospice care less than 2 weeks, but I know she was comfortable. So my questions are, why would a nursing facility try to dissuade a caregiver from choosing hospice in addition to palliative care? Is there a financial reason? Wouldn't you think nursing homes would welcome the extra help and equipment?
I might have an answer for that. It depends on what facility it was, but I can tell you that not very many of the facilities do it, but Medicare does have a benefit that will pay the facility extra, like they were a Med A patient, a skilled patient, to provide palliative care.
Oh, interesting.
I don't know that that's the case in here, but it is. It is something that Medicare does provide to the facilities, and also it could be just a matter of the facility not understanding, needing more education. I'm sad that they had to go through that.
Yeah, I was going to say the same thing. I think that, again, so sort of what I said just a few minutes ago, this lack of understanding of what palliative care is and what hospice care is, and not being able to marry that. I find that often in facilities as well. So not only the people that I work with every day in the hospital don't fully understand it, the community doesn't fully understand it. And so I don't expect a nursing facility to either understand that unless they have a palliative care provider that's embedded in their system, which lofty goals, that would be fantastic. Maybe that's in my 5-year plan for our program to be embedded in the facilities here. But the fact of the matter is, sometimes people just don't fully understand. And so I feel very strongly that if you see your loved one suffering, you can always call. You can always call our office, or another local palliative care provider and say, hey, can we talk about this, and can we figure out if we need to change focus here, or improve the care that my loved one is getting. Don't be afraid to ask questions of your medical providers. And if it's the facility that's blocking things, then go to the doctor or the advanced practice provider that you're seeing.
Right.
Say, hey, I'm really worried about mom's well-being. I think that she's suffering needlessly. And is there somebody that can support me in making sure that she's not suffering? It's okay to ask questions and question the norm. And if you're not getting the answers that you need in one place, then you go to the next place and you find that. It's okay to ask questions of your medical providers. Please do. That's why we're here.
Right. You are never going to steer yourself wrong if you trust what's going on in your heart. You just trust that. And because once you get over into palliative care and hospice care, that's where we're working from almost daily. So, we have to think things through, but the care comes from the heart, not from the head. So if your heart's telling you this isn't right, follow it through.
I appreciate
Thank
that.
you.
Thank you. We've got some audience questions here, and we are welcoming more. We've still got some time. Please feel free to use the Q&A feature at the bottom if you're able to. So this was a question that was asked near the beginning, and it's an anonymous attendee asking, as a person who has outlived my life expectancy and am looking for a medical care person knowledgeable about aging, I find it discouraging to find that person. Where are they?
Oh. Nicole, do you want to take that one?
It's difficult.
Sorry, throw you under the bus.
No, yeah, I think that's a really great question. My go-to answer is, well, we know about aging, so you can always come see us. One of the things that I try to teach patients and their families is that as we age, and this is kind of going back to Amy's comment about frailty as we age. And so that there are things that change, and our bodies don't bounce easily when they're stressed. And so I don't have a great answer for you as to specifically, is there a provider that you should go to? If you have questions or concerns, again, reach out to your primary care provider. And if you're not getting the answers that you need, or you feel like there's something else that needs to be checked into, or you have questions about whatever your health problems are and what to expect long-term from them, we're always happy to at least field a question or see you even as a one-time visit to figure out if there's something that we can do from a palliative care standpoint. So I'm going to back up just a little bit because this conversation of frailty, one of the things that we have implemented here at the hospital is seeing our patients who are what we call geriatric traumas. So those are people that fall down and break things often. So if you have more than just a fall down and break a hip or an arm or something, those usually get sent on to KU or other facilities that are at a higher level of care. But we are seeing a large number of our geriatric traumas, so mostly hips, arms, those kind of things, because as we age, like I said, we don't bounce as well. And so the story that I always say is that people are like rubber bands. So you have a brand new rubber band and you get it out of the drawer and you start to stress it and it bounces right back to normal. But then you go, you're looking for a rubber band and you go and you reach in the back of the drawer and you find the rubber band that's been in there for 10 years. And you look at it and you're like, yeah, I think this is going to work, but I know that I can't stress it too much. That's exactly how bodies are. So even if you're a perfectly healthy 90-year-old, which is few and far between, many 90-year-olds have other health problems. And so even if they're well managed, as we start to stress them, their rubber band doesn't tolerate that stress very well. So we start to see those cracks and fissures, and maybe that rubber band bounces back, but it's not quite the right shape, or it bounces back, or it takes a really long time to go back to normal. And sometimes they break. And so that's the challenge in taking care of chronically ill people. So not only aged people, so people who have outlived their life expectancies, but also people who have lots of serious illness. If you're 60 and you've got multiple health problems and you're not very functional, so when I say functional, you're not able to be up and around and doing things on your own, you're needing more and more assistance, you're not able to move around as much, you are at a higher risk of dying when you get stressed. And so how do we make sure that we are doing the things that we need to be doing that are in concordance with your wishes? So we're doing the things that you want us to be doing, but we're not overdoing things, because we can throw the book at you and do all kinds of cool things. But if that's not what you want us to do, then we need to be talking about that. And I know there was a question about having those conversations with your family and how do we document those wishes. So there are several places that you could go to look into that. So getpalliativecare.org is kind of an informational website about palliative care. There are resources on there about conversations. One of the tools that we use are called 5 Wishes. So that's a booklet that you can go through, and it helps you identify things that are important to you, and help you document, how you want to be cared for as your serious illness progresses. In the state of Kansas, there are some specific documents that we use. The first thing is like I said earlier, is to designate a power of attorney for healthcare. And so that's not the same thing as a general power of attorney. We often get people bringing those in. Well, that's not your decision maker for when your health problems are such that you can't make decisions for yourself. So there's a specific form for a durable power of attorney for healthcare. So you get your decision maker. And I always say maybe pick 2 people. That way, if person 1 isn't available or struggling, then you've got person 2 to make those decisions. The second thing that we have available in the state of Kansas is a living will. Typically, living wills talk about how if I have a terminal illness as certified by 2 physicians, I would not want you to do aggressive life-sustaining interventions. So by that, I mean, I wouldn't want you to take me to the ICU. I wouldn't want you to put me on life support. I want you to just allow me to die naturally. The third form, so those 2 forms are great. And the living will it's okay. But there's a lot of gray area that happens before we get there, before we get to this terminal condition as designated by 2 providers. And so then we talk about utilizing the TPOP form. It's TPOPP, and it's the Transportable Physician Orders for Patient Preferences. It's a hot pink form, and it goes through 3 things. So the first thing it talks about is, if my heart stops or I stop breathing, would I want to have cardiopulmonary resuscitation, or CPR? So CPR is when we do chest compressions and we give medications and we help aid in breathing to try to bring you back to life when you're dead. So that's part 1. Part 2 talks about, do we throw the book at you in terms of how aggressively we care for you? So do we do everything possible? We pull out all the tools in our tool belt to try to keep you alive? Or do we try to do things that are not as aggressive? Or do we really focus on your comfort? So when I say not as aggressive, sometimes patients are okay coming back and forth to the hospital. I'm fine if I get sick. I want to be treated. But if the things that you're doing to help me get better aren't working, then I don't want you to take me to the ICU. I don't want to be put on life support. I really want to be as comfortable as possible. But if things aren't going well, just allow me to die peacefully. And so that's kind of section 3, and then, or section 2. And this is a quick summary. So if anybody has questions, I'm more than happy to answer them offline. The third portion of that form talks about artificially administered nutrition. So that would be a feeding tube that goes in your nose temporarily, or whether that would be a surgically placed feeding tube. And there are certain times that those are appropriate. I would say that, the things that we talk about are, in the setting of an acute stroke, where swallow, it has been affected, and we expect it to be recovered. And also like an acute traumatic injury. So my trauma experience, we would often put feeding tubes in for patients that had traumatic brain injuries, or had injury to their face where they couldn't swallow, those kinds of things. But what we have found is that in chronic progressive illness, in cases such as dementia, Parkinson's, ALS, those kinds of things, feeding tubes really aren't effective. They may provide temporary improvement, but the fact of the matter is they're not without complication. They can cause a higher risk for aspiration, so getting food and fluids into your lungs. They can cause skin breakdown because most of those nutritional devices, the solutions that we use, can cause diarrhea. And the big part of it is that it just doesn't prolong your life. You're still going to follow that same trajectory, even if we're providing a little bit of nutrition. And so that form is great because it kind of better identifies things for people, but it better delineates how we care for you in the hospital. So there's a question over here, so I'm just going to answer it because it's a great question. So is TPOP a universal form, or is it just Kansas? So most states have a type of this form. Kansas and Missouri share the TPOP form, and it stands for Transportable Physician Orders for Patient Preferences. And it took me like 2 or 3 years to finally remember all those words. So don't feel bad if you can't keep it straight. The other thing, so like some states use the POLST form, POLST. And I think it's Physician Orders for Life-Sustaining Treatments is that form. So many states have something. If you just Google that, you should be able to, I think there's a website that actually lists what document is available. I don't know what it is off the top of my head though.
Right. I'm going to say if you're 90 plus years old and you've outlived your what you see as a reasonable amount of time of living, you're probably not going to Google anything, but you could, one thing that's very easy to remember is 5 wishes. And that form that Nicole talked about is pretty comprehensive. It does cover how you want to be treated at the end of your life, as well as who's going to speak for you. So at the very least, find that 5 wishes form, have somebody in your family find it for you. And maybe in their search, they'll discover the POLST forms and other forms as well and help you with that.
Thank you. Quick question. Are hospice patients necessarily bedridden? Is that part of the Medicare guidelines?
No.
No. Okay.
No, it's not. They can be very ambulatory. Typically, they are needing some assistance with care, but they can be pretty much independent. But they need to be showing, over the course of time, they need to be showing some decline in order to stay on. A lot of it depends on what that diagnosis is too.
Okay. Makes sense. Okay.
Sometimes we don't see a lot of change until close to the end. So as long as they're meeting, a lot of our cancer patients are very independent when they come on. A lot of the cardiac patients are maybe not independent because they've had a pretty functional decline, but they are still able to kind of get up and walk around. So, I mean, it just depends on actually what that diagnosis is.
Thank you. So we have a question that's kind of related to what we've been talking about. Could you all identify some other resources for finding the documents that you need? I think as far as local goes, you can talk to the hospital or talk to these facilities to get copies of the documents. But do you know of any other websites that have them all in one place, or other agencies that would have them online all together?
No, not really. Not where they have them like easily accessible.
Okay.
All of the websites will talk about them, but they're pretty, I mean, unless Nicole, you know of one where you can just go and find all of them, it's pretty difficult, I think. So I would go back to what Dr. Wenzel said and use the Senior Resource Center. I know I like to use the NHPCO website. It's nhpco.org. And you can go there and get quite a bit of information about both palliative care and hospice. And they have a lot of they have a lot of links that could get you to where you're wanting to go. But it does become pretty
Overwhelming.
Overwhelming
Yeah,
is a good word.
Good way to say it. I was just as you were talking, Monica, I was just looking. So the getpalliativecare.org website, if you click on the left-hand side of the screen, there's a links. And if you scroll all the way down, there is a section that is titled medical decision making. So that has some of the links to those. So, and one of the people commented the conversation project. So that's another great tool. To start those conversations. And I wish that I could remember off the top of my head what this was named, but there was this group that suggested having these conversations over your holiday dinner. And so starting those conversations at hey, I know we're all together because everybody's together. We can have those conversations when everybody's sitting at the table. So that your family knows your wishes. I cannot think of it off the top of my head, but I've never broached it at a family dinner. I've thought about it. It's definitely been a conversation in my head, but I have not actually done that. So if anybody's brave enough to do that, let me know.
Well, I wonder with kind of safety regulations and things, if people are having virtual family dinners, it might be easier because
right.
You can turn off your camera if you get very uncomfortable. So maybe having those questions virtually or having those discussions virtually could ease some of the tension a little bit.
Yeah.
There was also the book mentioned, Being Mortal by Atul Gawande. That's a wonderful book. That book changed my entire life. I've read it several times. So highly recommend that book. If there's other books or resources y'all have, happy to type them into the chat box here.
I think one of the books that we actually give to patients when they sign on to hospice is by Barbara Karns. She's an RN that kind of is a pioneer sort of with hospice kind of it is called Gone From My Sight. And it's very easy to read. It's not too overwhelming. It's actually more of like a booklet, probably I think maybe 20 to 25 pages, but it just kind of lets you know what to expect during the process. And I always tell, because they get tons of information that we give them all kinds of information, when we go out. But what I always tell the family and the patient is that if you don't read anything else that I give you, because, it's a tendency to just throw it off to the side, read this book. And we get lots of positive feedback from that. And a lot of people have told us that, had they not read that, things would have gone a little differently for them. They feel a little less panicked. So I think that that's a good thing to look at, to read for anyone.
Okay, thank you. Thank you. We've got some other suggestions we put in here, final gifts, also extreme measures. Those are great resources as well. I do know for a library plug, we've got a couple of these books in the book club in a bag kit. Also talking about these issues with your book club might be a really wonderful way of normalizing them and talking about what your wishes are and kind of making yourself feel a little bit more comfortable surrounded by different kinds of loved ones.
And we also have what we call healing kits. Your book in a bag reminded me of, and it's specifically for children who are going through the grief process or are, and it doesn't necessarily have to be after that patient passes away. We have that we're divided up into age groups with pre-K through 4th grade, 5th grade through junior high, and then high school. And our books, actually, we've had like some 20 and 21-year-olds actually ask for some of those. And that's one of the things that we do on admission is we try to identify if there's going to be children that are going to be going through that. And our social workers will take those out to them. We also have sent some out into the community to some of the schools that have gone through some things. So that's a great resource too. And if anybody's interested in those books, I can send you a link, maybe Kate, to send you a list of what books are on there. And
absolutely.
What you'll find is if you just start educating yourself with any one of these things, you're going to find more and more things and really start to get a truer view of what end of life really is and what it means and what it's about.
Absolutely. Thank you so much, all of you. I learned a lot, and I hope everyone did too. I will say that the next Lunch and Learn that we have in November, it's the 3rd Wednesday of November, that is going to be talking about how to talk about grief with folks who are grieving, also how to talk about your own grief, and other sort of topics that are kind of interpersonal conversations. So always looking for more questions then. We've got a great comment that someone feels more empowered to bring up these conversations with their loved ones. So that's exactly what we were looking for. So thank you so very much. If you end up having any other questions, you can contact the library. You can, message us on Facebook or look up the Before You Check Out series on Facebook or on our website. Reach out, we can connect you with these resources, and we're happy to talk more. So thank you all so very much.
Thank you.
Thank you.
Thank you.